you so much. We will go a bit into neurology, and the first thing is stroke. Stroke management has also changed over the years, and now we can do much better than we used to do. And the role of family physician in stroke has also become significant. First of all, just a bit, if a patient comes to you with hemiplegia, for example, and the patient has come within 10 minutes, 15 minutes, that hemiplegia may recover because it was a TIA. Initially, we used to think that a TIA means 24 hours recovery is possible. Now, we think that TIA should be defined by less than a few minutes of recovery. So if the patient has come with 1 hour of paresis, this is a patient who might benefit with thrombolysis. So the window, what is the window for thrombolysis now, intravenous thrombolysis?
So they keep changing, it used to be 3 hours, then it became 6 hours. Now I think they're even talking of 24 hours and things like that. But intra-arterial thrombolysis is 3 hours and sometimes extendable to 6.
Okay. The commoner thrombolysis with a thrombolytic agent called tenecteplase is the window given is 4.5 hours for intravenous thrombolysis. And within that 4.5 hours, what you need to do is diagnose that this is an ischemic stroke and not a hemorrhagic stroke, because you can't give thrombolysis in hemorrhagic stroke. So what is the modality that they should send a patient immediately for? An MR or a CT, because we know that hemorrhage can be detected on CT also. What should they send it for?
Can I move one step back here? So I think, when Tushar said patient comes to you with hemiplegia, if given the traffic situation and all the other issues in Mumbai, I think first you may get a phone call saying that a person is hemiplegic. And I think it starts from there. If you are quite convinced that the patient has a stroke on the phone itself, I think the only option is to go to a hospital that manages stroke. So that would mean Nanavati Max here, Kokilaben, Reliance HN in South Bombay, and each Hinduja, I think each 3 or 4 months a new hospital is able to establish a 24/7 stroke unit. First one was Kokilaben, and then now more and more hospitals have it. Because if you are going to either go to their house or wait for them to come to you, then maybe get a CT scan done at a scan center, wait to talk to the radiologist, see the report, then decide if the patient is a candidate for stroke, you've pretty much lost the window. So I think the most important thing is that clinically, if you think the patient has a stroke, even at the risk of over-investigations, the patient needs to get to a stroke unit, where then they will decide what they want to do. It will start with a plain CT or a perfusion CTA. And then based on that, they will decide whether or not thrombolysis is required, whether it's intravenous or intra-arterial, whether, all of that decision making will then happen. But I think more than anything else, the most important thing is for the patient to reach a hospital that has a 24/7 stroke unit. That is the only critical point in all of this.
So as I said, a very important thing for us is to do a video call and find out that this is a stroke. Because if that is done, then the patient need not struggle. Of course, we will sometimes get the patient directly coming to our clinic, not realizing that they had to call you. But otherwise, a video call is mandatory. And I do believe that though a lot of our family physicians, consultants, they kind of, से कि मैं इतने बजे के बाद मोबाइल फ़ोन ऑन नहीं रखूँगा, मैं ये कहूँगा, and we all have our own opinions on how much privacy we need and how much. I do believe that myocardial infarction and strokes are often telephonically diagnosed easily, and if you can afford to keep your mobile phones on, even at odd hours, mine is on 24 hours, and I never, I try not to miss calls, or at least the calls are diverted to my assistants. So I would say that these two emergencies are such that you can actually save a patient's life. What he said is, usually there's a corridor in say Nanavati Hospital. If the patient of a stroke goes to the casualty, from there the patient goes straight to the CT or MR center, gets a scan done, and then the procedure goes forward. What is